So this factor that we will be looking at next is health literacy, and how health literacy affects access to health services. So what is health literacy? Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. What does health literacy cover? Health literacy refers to the overriding factors, barriers, and the education important in accessing and understanding health information. Put simply, health literacy involves reading, writing, listening, speaking, numeracy, and critical analysis to perform health-related tasks. Statistics reveal that over 1/3 of the adult population has limited health literacy. Only 40% of adults have adequate health literacy levels to meet demands of everyday life. Limited health literacy includes medication errors, increased healthcare costs, inadequate knowledge, and the inability to manage chronic health conditions. Low health literacy increases the risk of serious illness, needing emergency care, mismanaging medication, poor health in old people, not getting the flu vaccine, being hospitalised, and not understanding diseases and conditions. Low levels of health literacy can be linked to lower participation rates in preventative health approaches such as vaccinations and cancer screening. This occurs when there are low levels of socioeconomic disadvantage, existing language barriers, and general education. High levels of health literacy, on the other hand, occurs when people have access to a greater range of health services and use health information to enhance overall health and well-being. Health literacy is using the information to make good decisions based on a holistic understanding of health services and how to best access and use these services. Health inequalities refer to varying health statuses, illness, and mortality of individuals and social groups that result from social, economic, and geographic contributions. Health inequalities result in unequal access to resources necessary for optimal health. The 7 kind of areas that we'll be touching on for health literacy and health inequalities are meaningful employment, education, adequate housing, accessible health service infrastructure, healthy eating, safety and justice, and urban planning and transport. So these kind of subheadings of health literacy are factors that contribute to enhanced or decreased access to healthcare. So when considering health inequalities, we must address this holistically, e.g., how low income and unemployment impacts more broadly on health. For example, these barriers to health access may result in social isolation and exclusion. If someone believes they are being treated unfairly, this may result in a lack of trust toward institutions and lack of social connections. Terrell et al. 2007 state that health in middle to late adulthood is shaped by experienced childhood socioeconomic conditions. Thus, there is a significant contribution of the accumulated disadvantages obtained over an individual's lifetime. So expanding on these 7 factors that contribute to access to healthcare that we're exploring under health literacy. Number 1 is education. So poor health. People with poor education are more likely to be employed in jobs lacking security, with approximately 40.1% of Indigenous students finishing a Year 12 education compared with non-Indigenous student completion of 75.9%. Good health, based off good education, enhances knowledge about health such as enhanced awareness of harmful behaviours, increased job opportunities, increased self-esteem and self-worth, and also lifelong learning is linked to prevention of the onset of disease such as Alzheimer's disease. Next factor, access to employment. So poor health is often linked with individuals without job security demonstrated the lowest levels of self-rated health and subjective well-being. So unemployment may result in depression, low self-esteem, and mental health problems. Unemployment can be linked to increased drug and alcohol abuse, and interestingly, statistics show that unemployment rates for Aboriginal people stands at 12.9 compared with non-Indigenous people at 4.4%. In 2007, 9.5% of Australian children aged 0 to 17 years live in households without an employed parent. Good health based off access to employment offers financial independence, self-confidence, and control over health services. The next factor, income and wealth. So poor health is linked with low income, which results in a reduction of access to resources and medications to improve overall health. Increased risk due to greater exposure to physical hazards such as faulty home equipment, and risk of premature death is higher with poor income and wealth. Good income and high income results in greater home environments, up-to-date technology, and greater access to resources and services that complement a cost. So poor access to housing results in insecurity due to unaffordability, which can also lead to uninsulated houses and greater inequities and inequalities in health. Greater risk to individuals living in rented accommodation was found within statistics, and overcrowding often resulted in decreased health and well-being due to increased disease and greater demand of bathroom and laundry services. Good health through effective access to housing gave individuals access to clean, insulated, and adequate housing and housing which reports back greater levels of health. This is due to being and living in better conditions and having greater access to health services and adequate heating and cooling. The next factor is healthy food, and a statistic stated that almost 60,000 Australians in low-income families go without meals or experience food insecurities. Poverty and low income results in lack of access to food, leading to greater possibilities of eating disorders and lower health. Disadvantaged communities in Melbourne have up to 2.5 times the exposure to fast food outlets. Good health and access to healthy food enhances physical and mental well-being. It's known to enhance cultural and social growth, such as cooking and sharing food. Next factor, health, social, and community infrastructure. So poor access to community infrastructure leads to inadequate health care, which results in conditions being left untreated, resulting in serious health consequences. Patients in low socioeconomic areas are less likely to receive longer GP consultations than patients in more advantaged areas. Good access to health, social, and community infrastructure enhances the capacity of individuals to maintain optimal health and alleviate illness. Participation in organised sports and community involvement enhances overall health and well-being. And the last factor we'll look at is urban planning and access to transport. So statistics state that 9.3% of unemployed Victorians have difficulty with transport when getting to places they need, compared to 1.6% of full-time employed Victorians. In 2003, 30% of Victorians who were living with a disability had some difficulty with public transport access. In contrast to this, good urban planning and access to transport results in greater health due to enhanced accessibility of health services and information.